Hello, my name is Rémy Duléry. I work in Paris Saint-Antoine in Sorbonne Université. And my goal for the next minute will be to talk about CAR T-cells in lymphoma. I will try to present the new advances and focus on practical aspects. These are my disclosures. Chimeric antigen receptor T-cell therapy is an autologous cellular therapy in which a patient's own T-cells are engineered to recognize and attack tumor cells. Synthetic CARs are hybrid proteins consisting of an extracellular single chain variable fragment fused to a transmembrane domain, and then to intracellular co-stimulatory signaling domain. The incorporation of co-stimulatory signaling in the CAR structure has revolutionized the field of CAR T-cell therapy and enabled their successful application for the treatment of relapsed refractory B-cell malignancies. For the purpose of this talk, I will focus on a regulatory approved commercial CD19-directed CAR T-cells for non-Hodgkin lymphoma. Four type of products have been approved, and one of them is T-Zagen Leucocell from Novartis. Another one is Captagen Siloclocel from Gilead Kite. A third one is Brexucaptagen Autolocel from Gilead Kite. And the fourth one is Lisocaptagen Maralocel from Juno Therapeutics Celgene Corporation. But first, before explaining all about CAR T-cell, I would like to start with the reason why CAR T-cell has been developed. Well, thanks to the SCHOLAR-1 study, we know that patients who are refractory to at least one prior line of chemotherapy have very poor outcomes. Salvage therapy in those patients are associated with very low rates of response. The overall response rate is only 36%, and the expected complete response rate is only 7%. The 2-year overall survival is only 20% without CAR T-cell. For these reasons, CAR T-cell therapy have been developed, and I'm going to start by showing you the efficacy results. First, with T-cell, it has been evaluated in the Juliet phase 2 trial in 111 patients who received at least 2 prior lines of therapy. The overall objective response rate is 52%, and the complete response rate is 40%. At 1 year, the overall survival for all patients is 49%, but as you can see, it's much better in patients with complete response, with an expected 1 year overall survival of almost 80%. With longer follow-up, the 3-year progression-free survival is 31%. Among all responders, 60% were estimated to maintain that response at 2 and 3 years. We recently had data published in the New England Journal of Medicine of the first 24 patients who received T-cell. The objective response rate is 58%, and the complete response rate is 46%. With a median follow-up of 60.7 months, the 5-year progression-free survival is 31%. What is interesting is that the median duration of response was of more than 5 years, and 60% of patients had a sustained response at 5 years. Well, 31% of PFS may not be a lot, but if patients respond, it proves that the response can be sustained with the persistence of CAR T-cell. Another product is axi-cell. It has been evaluated in the ZUMA-1 phase 2 trial, including 101 patients. The overall response rate is 83% and the complete response rate 58%. At 2 years, the overall survival is 50%. With a longer follow-up, the 4-year overall survival is 44% in the same patients. A third product that has been approved for aggressive B-cell lymphoma is liso-cell. It has been evaluated in the Transcend NHL-001 trial. 256 patients have been included. The overall response rate is 73% and the complete response rate 53%. At 1 year, the overall survival is 58% and the progression-free survival 44%. The duration of response is 54.7%. CAR T-cells are also efficient in mantle cell lymphoma. The first approved CAR T-cell product is Breakthrough Cell, which has been evaluated in the ZUMA-2 phase 2 trial in 74 patients who were relapsed or refractory to BTK inhibitors. The overall response rate is quite impressive. It goes up to 93% of the patients with a complete response rate of 67%. As you can see, the 1 year progression-free survival was 61% and the overall survival 83%. Another product has been evaluated for mantle cell lymphoma, but it's still not approved, is liso-cell. 32 patients received this product. 88% of them had received prior BTK inhibitors and 34% of them prior allogeneic transplantation. The median follow-up was 6 months, so we still need longer follow-up, but we can already see that the response rates are very high. The overall response rate was 84% and the complete response rate 66%. Very recently, it was the axi-cell has been approved by the FDA for follicular lymphoma. It was based on the results of the ZUMA-5 phase 2 trial, which included 84 patients with follicular lymphoma. There was also 20 patients with marginal zone lymphoma, but CAR T-cell are still not approved in this indication. So to come back to follicular lymphoma, the overall response rate was 94%, with 80% of the patients having a complete response. The 1 year progression-free survival was 74%, and the 1 year overall survival was 93%. With a long follow-up, very recently, Tisa-cell has also been shown to have high progression-free survival up to 43% in 14 patients, the first 14 patients who received the treatment. Now, those good results have only been seen in clinical trials in the slides I've shown you, but What about if you compare the results from clinical trials to the results of the real world? Well, as you can see here for T-cell, um, similar rates of tumor response in real-world series have been reported when compared with the results of the Juliet trial. And it's the same for axi-cell. We observe similar rates of tumor response and also similar overall and progression-free survival. So it means that even if the inclusion criteria are not the same as in the real world as in the clinical trial, you can expect the similar rates of response and similar duration uh, of response. Another way to evaluate the efficacy of CAR T-cell is to compare it to conventional alternate therapies. It was done in a retrospective study including 215 patients. The first message is that the complete response rate is significantly better with CAR T-cell compared to alternate therapies. It was 52% with CAR T-cell compared to 22% with alternate therapies. And as you can see here on the Kaplan-Meier curves, the progression-free survival and the overall survival are significantly improved with CAR T-cell compared to alternate therapies. If you look at the results according to the number of prior lines, the advantage of CAR T-cell compared to alternate therapies appears to persist irrespective of the number of lines of prior therapy. However, after adjusting for unfavorable pretreatment disease characteristics, superior overall response rates in the CAR T-cell cohort remain significant, but the differences in progression-free survival and overall survival between cohorts were not significant anymore. This means that in selected clinical scenarios, alternate therapies might be as efficacious as CAR T-cell therapy. Now, after showing you the efficacy results, I would like to go through very practical aspects of the procedure of the CAR T-cell. It starts with the patient, of course. The right selection of the patient according to his age, according to his comorbidities. Very important consideration when judging eligibility for CAR T-cell is the patient's ability to tolerate the therapy, which is determined by the Karnofsky performance status or the IACH performance status. As you can see in these real-world data, there is a very strong impact of the performance status. The progression-free survival and the overall survival is significantly better with the performance status 1 compared to performance status of 2 to 4. The other very important consideration organ function, which can be assessed as comorbidities. In this same study from NAS2PIL and HAL, from showing real-world data, you can see that patients who had no comorbidities had much better progression-free survival and overall survival compared to patients who had at least one comorbidity. The age of the patient is, however, likely not a factor which should prohibit CAR T-cell therapy. As you can see here on the Kaplan-Meier curves, overall survival and progression-free survival are similar if you compare patients younger than 60 years to patients of 60 years and above. Of course, there is a selection of patients according to their comorbidities and performance status, but with the right selection of patients, it's possible to offer this therapy to elderly patients, and you should not think of age as an absolute limit for these patients. From a very practical point of view, the selection of patients for CAR T-cell therapy must usually satisfy the following requirements. A ECOG performance status of 1 or 0, an adequate blood count with absolute neutrophil count above 1,000, absolute lymphocyte counts above 100, and platelet counts above 65,000. Patients also should have adequate renal, hepatic, pulmonary, and cardiac function. Now, to go after the selection of the patients, the second thing you should look at is the disease features. These are the approved indication of CAR T-cell therapy. It is now approved as a treatment of adult patients with the following B-cell lymphoma refractory or relapsing after 2 or more lines of systemic therapy. Diffuse large B-cell lymphoma, DLBCL arising from follicular lymphoma, DLBCL arising from indolent lymphoma, high-grade B-cell lymphoma, primary mediastinal large B-cell lymphoma, follicular lymphoma of grade 3B, and very recently, follicular lymphoma with grade 1, 2, and mantle cell lymphoma. So it means that for most B-cell lymphoma, it's not possible to use CAR T-cell when they are refractory or relapsing after 2 or more lines of treatment. In the clinical trial, there was a contraindication to use CAR T-cell in case of detectable cerebrospinal fluid malignant cell or primary central nervous system lymphoma. However, data from real-world experience suggest that CAR T-cell can be successfully and safely used in patients with active CNS disease. I show you here the results of a study including 8 patients with secondary CNS lymphoma treated with T-cell. Very interestingly, no patients experienced neurotoxicity grade 1 or above. No patient required tocilizumab or steroids for toxicities. The biomarker analysis suggested that CAR T-cell expansion happened despite the absence of systemic disease. Early response assessment demonstrated activity of infused CAR T-cell within the central nervous system space. And you can see here on the left side of the screen, the MRI showing a complete response at day plus 30 in one patient. Now, the question is, what are the predictive factors of early progression? How can I better select the patients? And in other words, for which patient can I expect the best response? This has been evaluated more especially in one study, including 116 patients. They received either axi-cell or T-cell. The median follow-up was 8.2 months. 47% of the patients failed treatment. 49% of relapses occurred early, which means within the first month after CAR T-cell treatment. So what you can see that in multivariable analysis, independent factors of early relapse were at the time of decision to use CAR T-cell, which is at the time of leukapheresis. It was elevated LDH and an ECOG performance status of 2 or above. At the time of treatment, which means at the time of infusion of CAR T-cell, factors associated with early relapse were the number of extracellular sites above 2, elevated CRP, and a tumor metabolic volume above 80 milliliter. This study created a risk model identifying early failure. This is a very interesting model, fairly balanced, which identifies 3 risk groups. It is more discriminatory than IPI and revised IPI scores, notably because it can identify a group with very good prognosis. And I think this risk model can assist in a better selection of patients. It is very easy to use. There are only 2 factors: the number of extracellular sites of 2 or more, and the metabolic volume above 80 milliliter. You count 0 if you have 0 factor, 1 or 2 if you have 1 or 2 of these factors. And if a patient has 2 factors, you can see that the progression-free survival is very, very small. Now, what about leukapheresis and bridging therapy? One of the limitations of the use of CAR T-cell is that patient's disease needs to be relatively stable while CAR T-cell are manufactured and sent back to the treating institution. In general, there is a period between leukapheresis and lymphodepletion, which varies depending on the product and can be anything from 3 to 6 weeks. During this time, or sometimes before leukapheresis, the patient may or may not require bridging chemotherapy to stabilize the disease, prevent rapid progression, and ensure the patient is at optimal fitness at the time of CAR T-cell infusion. In the real-world experience of axi-cell for relapsed refractory DLBCL, the US CAR T consortium analyzed the role of bridging therapy prior to CAR T-cell infusion. Approximately half of the patients received bridging therapy. For half of the patient, it was chemotherapy. Sometimes it was steroids alone or targeted agents in 10% of the patient, or radiation therapy in 16% of the patients. Patients with poor performance status, high tumor burden, and high IPI score at time of infusion were most likely to receive bridging therapy. The rates of CRS and neurotoxicity were not different from those who did not receive bridging therapy, and there was no significant difference in terms of overall response rates, complete response rates, or progression-free survival. After leukapheresis, then there is the lymphodepletion. Well, fludarabine and cyclophosphamide is the most common lymphodepletion used prior to CAR T-cell infusion. Addition of fludarabine to the lymphodepletion regimen improved CAR T-cell persistence and disease-free survival. It is usually administered on 3 days with 3 days of fludarabine and 3 days of cyclophosphamide. The dose of cyclophosphamide may vary depending on the type of the product used. You may also want to use bendamustine as a lymphodepletion. It has been shown to be feasible in 24 patients who received T-cell. The overall response rate was 46%, and the 3 months progression-free survival 52%. There was no grade 3/4 CRS, and only 4% of grade 3 ICANS. What is interesting is that the response to the lymphodepletions may impact progression-free survival. Further developments of lymphodepletion may try to increase the dose of cyclophosphamide. As you can see here in this study from Seattle, is that higher doses of cyclophosphamide combined with fludarabine was associated with higher probability of a favorable cytokine profile and higher progression-free survival. After the lymphodepletion comes the CAR T-cell infusion. A transfusion set is required for the administration of the cells. Premedication, including paracetamol and antihistamines, is used to prevent adverse reactions. It is reasonable to use it with the important exception of corticosteroids, which may damage the CAR T-cell products. Infusion should begin as rapidly after spiking as possible, but no later than 30 minutes thereafter. In general, it is necessary that in vivo expansion occurs in order to have a clinical response. Patients with a high level of expansion of CAR T-cell are more likely to respond than those that do not have such as levels. Now, let's talk about supportive care and the prevention and management of early complications. Ideally, patients should stay in the hospital for at least 14 days after the infusion. For outpatient care, clear protocols, staffing, and training need to be in place so that patients are able to access a coordinator on a 24/7 basis. Both immediate review and emergency admission of patients under the care of experienced staff should be possible anytime. From a practical point of view, it's very difficult to have only outpatient care, and that is why, at least in Europe, we only do inpatient hospitalization for at least 14 days after the infusion of CAR T-cell. From hospital discharge to day plus 28 post-infusion, it is important that patients are located within 60 minutes of the treating unit because there are still side effects which may occur. One of the side effects is infection. It may occur in 23% of the patients within the first month after CAR T-cell infusion. Between day plus 28 and day plus 90, 14 patients may also have infection. Infections are life-threatening or fatal in 4% of the patients. And what is interesting is that the only factor associated with infection in multivariable analysis is the cytokine release syndrome severity. Overall, 1 out of 3 patients have prolonged neutropenia, and as I've shown you, infection might occur in about 1 out of 4 patients. These are the EBMT recommendations for supportive care and infection prophylaxis. There is no need for a systematic antibacterial prophylaxis. However, it is recommended to use valacyclovir as antiviral prophylaxis from day -5 until 1 year after CAR T-cell infusion, or at least until you have more than 200 CD4 cells per microliter. It is also recommended to use an anti-pneumocystis prophylaxis for the same time period. There is no recommendation, no strong recommendation for the use of systematic antifungal primary prophylaxis, except for selected patients. If your patient has a history of prolonged neutropenia, or if he develops prolonged neutropenia after the infusion, you should consider using antifungal primary prophylaxis. And the same goes for patients who have a history of allogeneic stem cell transplantation. There is a debate about the use of GCSF after CAR T-cell. Well, it was recently shown that administering GCSF from D+5 as prophylaxis in neutropenic patients is safe. It does not worsen toxicities. It does not increase the incidence of CRS or neurotoxicity, and it does not compromise the efficacy. Therefore, I recommend the use of GCSF when patients are neutropenic after CAR T-cell infusion. Now, let's talk about cytokine release syndrome. It is the most common complication after CAR T-cell therapy. The activation of CAR T-cell is the triggering event of CRS. This leads to the release of effector cytokines. CRS usually occurs between 1 and 14 days after CAR T-cell infusion and can last for 1 to 10 days. The incidence depends on the type of CAR T-cell therapy, the disease characteristics, and the grading system which has been used. Risk factors for CRS include tumor burden, the presence of active infection at the time of the infusion, the dose of infused CAR T-cells, the type of CAR T-cell constructs, and the choice of lymphodepletion regimen. You can see here the incidence of CRS depending on the type of CAR T-cell products. It ranges from 42% with lysocell to 93% with axi-cell in the ZUMA-1 trial for any grade of CRS. However, the most relevant and important is grade 3 to 4 CRS, and it ranges from 2% with lysocell up to 22% with Tisa-cell in the Juliet trial. As you can see here, there is no significant difference between clinical trials and real-life experience with axi-cell. The rates of CRS are very similar. So the first step with CRS is to grade the severity of this complication. The severity is very variable, and it is evaluated according to a novel grading scale recently proposed by the ASTCT consensus panel. Actually, it's very easy to use it. If you go on their website, they've developed an application, and you can enter all the parameters and grade and monitor the CRS in your patient. CRS should be monitored day and night, every 4 hours for each patient. In grade 1, there is only temperature above 38 degrees, no hypotension, no hypoxia. Then hypotension and hypoxia occur with the grade 2 and with only low flow of nasal cannula for hypoxia. When hypotension requires vasopressor, it becomes a grade 3, or when hypoxia requires high flow nasal cannula, face mask, non-rebreather mask, or venturi mask, it is also a grade 3. Finally, when hypotension requires multiple vasopressors, and or hypoxia requires positive pressure, intubation, and mechanical ventilation, it is a grade 4. As soon as it becomes a grade 2, you have to alert your local ICU reference. For grade 1 to 4, you have to perform blood cultures and other infection tests, start preemptive broad spectrum antibiotics, and symptomatic measures such as antibiotics, fluids. But you must bear in mind that corticosteroids are contraindicated in the absence of life-threatening complication. For the sake of time, I will not develop the whole algorithm for the management of CRS, but you can find it in this publication from Ibrahim Yakubaga et al. In Hematologica. It is the BMT recommendation. But to summarize it, the treatment of severe cases, in addition to symptomatic measure, consists of the administration of tocilizumab, which is a monoclonal antibody against interleukin-6 receptor. Tocilizumab should be administered no more than 4 times during one episode of CRS. Corticosteroids are used for grade 3/4 CRS in the absence of improvements in grade 2 CRS after the use of tocilizumab. You can use a second-line treatment, ciltuximab, which is another monoclonal antibody against interleukin-6. Now let's talk about neurological toxicity, also called immune effector cell-associated neurotoxicity syndromes, ICANS. The median time to onset of the first neurological symptoms is 5 to 10 days. Most ICANS occur during the first month after the CAR T-cell infusion, although this complication might occur up until day plus 100 after the infusion. The duration of symptoms is generally between 2 to 9 days. Here is a summary of the rates that have been reported in the main studies of CAR T-cell. You can see that for any grade neurological toxicity, it ranges from 26 to 70% depending on the study and the CAR T-cell product. For grade 3 to 4 ICANS, it ranges from 10% with liso-cel up to 35% with acti-cell in the real-world experience. So to evaluate the neurological toxicity, I recommend to use this score, this ICE score, which is called Immune Effector Cell-Associated Encephalopathy, which has been published by Lee et al. And is also available if you want to use it on the ASTCT website. It's a very easy 10-point score you can use. For grade 1 neurological toxicity, the main symptom is a decreased level of consciousness associated with an I score from 7 to 9. For grade 2 neurological toxicity, you have an alteration level of consciousness affecting activities of daily living. The patient can be awakened with the voice. The I score is 3 to 6. For grade 3, it's a very altered level of consciousness. Any clinical seizure focal of general that resolves rapidly, focal local edema or neuroimaging, or I score of 0 to 2. And grade 3 is life-threatening emergency. It's patients that is unrousable or requires vigorous or repetitive tactile stimuli to arouse. It's also a stupor or a coma. It's a life-threatening prolonged seizure, or it's a deep focal motor weakness, such as hemiparesis or paraparesis. The I-score is at this time impossible to perform. At any time when you have any type of neurological toxicity, even grade 1, you must contact your local ICU and alert your referral neurologist. You need to have rapid access to this expertise and perform cross-sectional imaging, electroencephalography, and cerebrospinal fluid examination. For the sake of time, I will not develop all the algorithm for the management of ICANS, but what you must bear in mind is that corticosteroids are used for grade 3 to 4 ICANS. Tocilizumab is added only in case of associated CRS. Now, what are the laboratory tests you should use to monitor your patients? Well, you should perform, of course, a daily hematology and chemistry usual laboratory tests. But in addition to that, I suggest to do a daily monitoring of C-reactive protein. You can also monitor during the CRS and ICANS period the ferritin levels and also the fibrinogen, because there are cases of disseminated intravascular coagulation, and you can only see it if you monitor the fibrinogen. Interleukin-6 could also be interesting to monitor, and the same goes for the CAR T-cell expansion. However, those two tests cannot be performed routinely in most centers. Now, let's talk about the prevention and the management of interim-term complications. Those are complications which occur between day plus 28 and day plus 100 after CAR T-cell infusion. The potential toxicity during this period includes delayed tumor lysis syndrome, delayed ICANS, delayed CRS, B-cell aplasia, hypogammaglobulinemia, which can sometimes require the infusions of polyphenol immunoglobulin in case of very low hypogammaglobulinemia under 4 grams per liter, associated with occurrence of infection. The infection may occur in about half of the patient during this period. One of the main complications that you can face is cytopenia, such as neutropenia, thrombocytopenia, and anemia in about 1 out of 3 patients. These are the tests that are recommended to use in your patients. You should monitor at every visit and as clinically indicated, a biochemistry panel, LDH, fibrinogen, and CRP. CMV, EBV, and adenovirus should only be monitored when clinically indicated, which means when there are symptoms suggestive of reactivation of such virus. You should monitor monthly immunoglobulins level or serum protein electrophoresis. Once monthly for the first 3 months, and then 3 monthly thereafter in the first year. I suggest to monitor the peripheral blood immunophenotyping with CD3, 4, 8, 16, 56, and 19. Finally, I suggest, if it's possible routinely in your center, to monitor the expansion of CAR T-cell. It can be useful in case of relapse, for instance. Now let's talk about prevention and management of long-term late effects. Very recently, it was published, as I shown you earlier, the results of the 5-year outcomes with Tisa Jean-Leclerc in diffuse large B-cell lymphoma and follicular lymphoma. What is interesting is that within 2 years, 69% of patients who were in complete remission beyond 1 year had recovery of B cells, and 82% had detectable CAR T transgene at the time of B cell recovery. At 5 years, 69% of patients had normal IgM levels, 56% normal IgA levels, and 38% normal IgG levels. Intravenous immunoglobulin treatment was started in 27% of patients who had a response. All patients who remain in remission beyond 1 year recovered normal CD3, CD4, and CD8 plus T cell counts. Well, these are the recommended minimum frequency of attendance at centers for monitoring for late effects after CAR T-cell. What is recommended is that in stable patients, they should come after day plus 100 every 3 months. But of course, the frequency will depend of any clinical event which may occur. Finally, let's have a quick talk about management of relapse. Relapse may occur in 40 to 70% of patients and is associated with poor prognosis. A consolidative allogeneic stem cell transplantation should be considered in case of response to salvage therapy. So which salvage therapy can be used? Well, any type of chemotherapy, but interesting results have been reported with the use of lenalidomide and anti-PD-1, which could modulate the expansion of CAR T-cells. Trials are evaluating the use of bispecific antibodies and the infusion of CAR T-cell for the second time. Let's talk quickly about the future perspectives for CAR T-cells. Very recently, it has been published the results of a second CAR T-cell infusion in 44 patients included in the phase 1/2 trial. What is interesting is that it is efficient and it doesn't seem to increase the toxicity. In non-Hodgkin lymphoma, the complete response rate was 19% and the partial response rate 33%. The median overall survival was 9 months. So overall, this is feasible and it may work even in patients who did not respond to the first infusion of CAR T-cells. CAR T-cells are also being developed in other diseases such as Hodgkin lymphoma and chronic lymphocyte leukemia. It was recently published that it is possible to use CAR T-cell with concurrent ibrutinib for relapse refractory CLL. It is well tolerated with low CRS severity and high rates of response, up to 83%. The 1-year PFS was 38% and 50% after CAR T-cells with or without concurrent ibrutinib. Other developments include new generation of CAR T-cell to overcome resistance, increase efficacy, such as tandem CAR T-cells, or CAR T-cell using trafficking, switch receptor, or adaptator, or cytokine secretion. You may also want to reduce the toxicity by using dual CAR or using inhibitors associated with a CAR, such as PT1 or CTLA4. This is only in clinical trials and being developed, but it is a hope for the patient. So to conclude, although the CAR T-cell era is still in infancy, and besides rituximab, I think it is probably the most important developments in lymphoma therapy. CAR T-cell therapy has demonstrated rapid response rates and improved survival in patients with relapse or refractory B-cell lymphoma. The objective response rate goes from 52 to 80%, and the complete response rate from 40 to 54%. So to conclude, although the CAR T-cell era is still in infancy, and besides rituximab, I believe it is probably the most important development in lymphoma therapy. CAR T-cell therapy has demonstrated rapid response rates and improved survival in patients with relapsed or refractory B-cell lymphoma. The objective response rates goes from 52 to 80%, with a complete response rate from 40 to 54%. With a long-term follow-up, axi-cell can allow for 4 years overall survival of 44%, and tisagenlecel has demonstrated that it can offer a 5-year PFS of 31%. Interestingly, is that you may not always respond to this therapy, but when you do, 60% of the patients remain in response. The median duration of response is above 5 years. Now, which is good news for the patients, CAR T-cell therapy has been approved for most B-cell lymphoma. However, the final role of CAR T-cell and its place in the treatment algorithm is still to be refined. There are several limitations in the use of CAR T-cell, and I think the main one is the inadequate bridging therapy for patients with rapidly evolving disease. And I believe that for this indication, B-specific antibodies might be more appropriate or actually more promising for very rapidly evolving patients because it's immediately ready. You can use it, whereas for CAR T-cell, you might have to wait for too long. The use of CAR T-cell therapy remains also impeded by the requirements for specialized care and by the economic consideration. The cost effectiveness analysis place it at a level that may not be feasible in some clinical settings. Finally, CAR T-cells are also limited by their toxic effects, which means that not all patients can receive it, but especially patients with altered performance status. The toxic effects include cytokine release syndromes in 2 to 20% of patients and neurologic toxic effects in 10 to 28% of patients for grade 3-4 events. Ongoing developments may, however, expand options in the future. We can hope for CAR T-cells directed at alternative or multiple targets. And we can also hope for the use of allogeneic off-the-shelf products. I would like to thank all my colleagues in Saint-Antoine, especially the nursing staff, for doing an amazing job taking care of the patient. I would like to thank you all for your attention.